The Knowledgeable Provider podcast is educational, entertaining, and not the same as medical training. The information presented here should not be used by anyone to diagnose or treat any medical condition in themselves or others. If you need medical advice, go see your own knowledgeable medical provider. Opinions expressed on the podcast are solely those of the people expressing them and are not necessarily representative of any other entities. Other than lunches at the office, I do not receive any sort of compensation from pharmaceutical or medical device companies. But I could. Big Pharma, where you at? But, alas, I have no financial disclosures. Okay, on with the show. Hello, welcome back to Knowledgeable Provider. I'm your host, Jody Marks. It's about time to end the sabbatical and get back to making podcast episodes. The book I was working on is all done. I'm still waiting on the audio book to be distributed. I waited very patiently for 3 weeks for their process that was supposed to take 10 business days and then sent them an email. And they were like, well, sometimes it takes 14 days. So at that point, it'd been 15 days. And then suddenly it was approved. So I feel like somebody wasn't paying attention, maybe. I don't know. But anyway, it passed their quality control process, which is excellent. Now it takes another 2 to 4 weeks, supposedly, for it to be distributed to all the different retailers where it goes. So more hurry up and wait with the book. There's been a lot of that with putting a book out into the world, I've learned. As soon as it's available everywhere, I've already made some promotional videos that I'll put out. I'm going to do a podcast episode about it and share part of the audiobook on the podcast. All that's already ready to go. I'm just waiting on it to be available for everyone. So coming soon, stay tuned. But in the meantime, I'm going to get back to our regularly scheduled programming. I'm going to talk about Rocky Mountain spotted fever today. If you've been listening, you know I've been doing an alphabet soup series for a while, going through the alphabet and choosing topics that start with the next letter in the alphabet, just as a way to keep things interesting and randomize a little bit the topics that I'm discussing. We have not made it to R yet, but I just saw a patient with this the other day. It's the first time I've knowingly treated a patient that has it, so that's why it's coming out of order. And of course, as you might expect, as people get outside more in the spring and summer, that would be the peak time for tick-borne illnesses to occur. So Rocky Mountain spotted fever sounds kind of exotic, right? Kind of cool. Oh yeah, I have Rocky Mountain spotted fever, or made up, however you want to look at that. But it is a real thing. It's caused by the organism Rickettsia rickettsii. That's a gram-negative bacterium that primarily targets endothelial cells inside blood vessels, small and medium-sized blood vessels. Obviously, we have a lot of blood vessels in our body, so this means it can show up many different ways and affect many different organ systems in the body. It's introduced by a tick bite and then spreads directly through the blood, where it's able to invade the endothelial cells and replicate itself in the cytoplasm of those cells, which leads to direct cellular injury and apoptosis, which is cell death. Obviously, the body's response to that is to turn on inflammation, the inflammatory cascade, if you will, and that tends to amplify the damage to the vascular endothelium. So the hallmark pathologic finding with Rocky Mountain spotted fever is systemic vasculitis, which of course can lead to increased vascular permeability, plasma leakage, edema, and microhemorrhages, which present as a petechial rash, another characteristic finding of Rocky Mountain. I'm just going to call it Rocky Mountain, so I don't have to say spotted fever every time. Or I guess I could call it RMSF. I don't know. We'll see how it goes. So characteristic finding, petechial rash, and vasculitis. Like I said earlier, this can affect every organ system. So depending on which blood vessels are affected, you might see different presentations, different symptoms with this. Of course, if the central nervous system is involved, you can see meningoencephalitis, cerebral edema, focal neurologic deficits. If it hits the lungs, you can get pulmonary edema and ARDS. That's acute respiratory distress syndrome. If it happens in the kidneys, you can get hypoperfusion and acute tubular necrosis. These folks can go into shock, of course, secondary to hypovolemia and hypoalbuminemia if you get a lot of vascular leakage going on. It can progress to DIC, disseminated intravascular coagulation, if you have a very severe fulminant sort of case. Children especially are prone to getting SIADH, that syndrome of inappropriate antidiuretic hormone. SIADH causes dilutional hyponatremia. Liver enzymes tend to go up, and GI symptoms are common with this. There are some other differences in how the disease affects adults and children. Kids under 10 years old are at higher risk for severe disease and higher mortality rate. Kids are more likely to present with really significant rash and swelling, especially periorbital and peripheral edema. This is one of those rashes that often affects the palms and soles, so that's always a standout characteristic of a rash because most things do not tend to affect the palms and soles. Syphilis is the other big one that comes to mind there, but that's always a good characteristic of a rash to remember. In kids, you're more likely to be able to see neurologic involvement on imaging. Specifically, there is a finding called the starry sky sign. These are multifocal punctate diffusion restricting or T2 hyperintense lesions that show up on brain MRI, often in children and hardly ever in adults. Interesting. I just read those words, by the way. I don't know what that means, but it sounds cool, doesn't it? I'm sorry, ma'am, your child has T2 hyperintense lesions. That sounds scary, huh? If you get a real severe form of this, if you get fulminant Rocky Mountain spotted fever, it can progress rapidly to multi-organ dysfunction, particularly if treatment is delayed during the first week of symptoms. In those patients, the incubation period is going to generally be shorter, like less than 5 days. So shorter incubation period tends to equate to more severe disease. If you happen to have glucose 6-phosphate dehydrogenase deficiency, you're very prone to getting super sick and dying with this. And then, of course, older people, people who drink a lot of alcohol, generally sicker people that you would think would be at more risk are also at more risk. This disease is endemic in much of the Western Hemisphere, certainly in the United States. Cases have also been reported in Mexico, Canada, Brazil, Colombia, Argentina, Costa Rica, and Panama. Here in the United States, most cases occur in the south central and southeastern states. Over half of the reported cases in the United States come from North Carolina, Oklahoma, Arkansas, Tennessee, and Missouri. In our patient's case that we're treating right now, they got a tick bite, found a tick about 10 days or so before the symptoms began. And of course, the first symptoms pretty non-specific, right? And then at the tail end of cold and flu season, that would certainly be the first thing to suspect when you start having fever, chills, body aches, etc. So I think they went to an urgent care first, and then they got sicker and ended up in an emergency room up in Virginia. And at the first visit at the urgent care, they didn't connect the symptoms with the tick bite. But by the second visit, they had kind of made the diagnosis on their own. They remembered the tick bite, looked up tick-borne illnesses, I suppose, and got directed down the path of Rocky Mountain spotted fever. According to the patient, whoever took care of them in the ER said that they'd never heard of Rocky Mountain spotted fever. I'm not sure whether to believe that or not, because it is sort of a regional thing. I suppose it's possible that whoever that was did their training somewhere else. Maybe it was a locum. But I feel like if you study tick-borne diseases at all, like if you are aware that there are tick-borne diseases, you know about Rocky Mountain spotted fever and Lyme disease, at least. And I remember studying this too in undergrad, in microbiology and parasitology classes that I took. So I don't know. I don't know if I buy that part of the story. It would have been interesting to be a fly on the wall during that discussion. But at any rate, the patient came in with a suspicion of this, and to their credit, they took it seriously and listened and tested for antibodies. The antibody levels came back elevated, so the patient was diagnosed with Rocky Mountain spotted fever. There are several different ticks that spread the problematic organism. I don't feel compelled to read the names of those ticks, but in different areas, there are different types of ticks that can spread it. Data from the most recent Rocky Mountain outbreaks in the United States suggests that fatality rates range from 5 to 7%. So people do die from this. The diagnosis is primarily clinical, especially during the first week of symptoms. The classic triad that they talk about is fever, rash, and known history of tick bite, which is probably the most difficult one to come up with. They say that quote-unquote classic triad is only present in about 3% of patients during the first 3 days, and then by the end of the second week, about 60 to 70% of people are going to have those symptoms. But again, very nonspecific symptoms in the beginning. Other things might include headache. Headache was a feature that our patient was very much affected by. That was really probably their main complaint, actually, after a couple weeks into the illness. Not feeling good, muscle pain, nausea, vomiting, and then sometimes swelling. GI symptoms more likely to be predominant in children, so sometimes this can actually mimic an abdominal surgical emergency kind of situation. And of course, sometimes people are not going to remember that they were bitten by a tick within the past week or two, as is the case with my patient. Or perhaps they were bitten and the tick eventually fell off and they never even knew it. So you can definitely see how that would happen. So in other words, we need to consider this with this kind of presentation, even if we don't have the history of tick bite. When we were talking about how this all came about, the patient said, "I can't believe nobody at the urgent care asked me about whether or not I was bitten by a tick." And I can see that in hindsight. That's a hindsight's 2020 thing, right? I've never worked in urgent care, but I suspect if you work at an urgent care and you see people with cold and flu symptoms all day, every day for your entire life, or at least through the entire winter, it's probably not top of mind to ask about tick exposures. So I can see both sides of that dilemma. Also, how many less common, rare, exotic diseases present with fever, rash, not feeling good, vomiting? I mean, I'm sure there are 100,000 different questions you could ask to rule out all these unusual diseases, but whatever, there's that. The gold standard for lab diagnosis is an indirect immunofluorescence assay for Rickettsia IgG antibodies. And in order to truly prove that that's what they have, you have to collect a sample within the first week of symptoms and then another one 2 to 4 weeks later. And there has to be a fourfold rise in titer. I always remember IgG as gone, right? IgG means that they had it before. So if we're looking for IgG antibodies, they're going to take longer to form. I suspect we will not be doing that sort of testing with my patient that we're taking care of. But so you can see how that would be problematic, right? Those kind of antibodies are not going to be detectable during the first week often. And then if we have clinical suspicion and we put somebody on the antibiotic treatment, that may blunt the formation of antibodies down the line. So testing a little bit shady, a little bit unhelpful. In practice, a lot of times with these tick-borne illnesses, what happens is the patient comes in and says, "Hey, I found a tick on myself yesterday. I'm worried that I have an infection." And you go, "Well, it's too early to test for anything, but why don't you just take some doxycycline and that'll get rid of whatever it is and we'll see you later." So I suspect we've treated this before and didn't know it. Same with Lyme disease. But in this situation, it was allowed to go on for longer and develop into more of an established illness before it was diagnosed. So that makes it a bit unusual in my practice. So this is something I've not seen before. You can also do PCR or nucleic acid amplification testing on skin biopsy specimens, ideally a specimen taken from where there's actually a petechial lesion, and ideally before antibiotics are started or within 24 hours of starting antibiotic treatment. You can do a PCR on whole blood, but it's less sensitive. The most useful in fatal or severe cases is immunohistochemistry on formalin-fixed tissue. So maybe that would mean tissue collected in an autopsy if the patient has already died. There are some point-of-care tests for this in development. There's a study that came out last year of a rapid antigen-based lateral flow assay targeting a protein called RC0497, if you care, that showed 95.5% sensitivity and 100% specificity in animal models. Apparently, if you interpret those rapid test results with AI enhancement, you can get the interpretation done in as little as 2 minutes, exceeding the accuracy of human analysis at 15 minutes. So maybe down the line, if you work in an area where this is endemic, you'll have rapid tests available for Rocky Mountain. I have to believe they're doing that for other tick-borne illnesses as well, but I don't know that. And as far as treatment of this, really it's doxycycline. That's for adults and children. There's a concern about using doxycycline in younger kids because of dental staining, but this is a fairly short course. It's 100 milligrams twice a day for adults, and then, of course, weight-based dosing for kids for like 5 to 7 days. And you want to continue it for at least 3 days after the fever has gone away and the patient is looking better. Generally, the fever is going to resolve within 1 or 2 days of starting the antibiotic if you start the treatment within the first 4 or 5 days of illness. So that was a bit of a confounding thing with our patient. By the time we saw them, they had been on the doxycycline for a few days. I want to say almost 7 days, and still felt like garbage, still had a fever. I think that's probably because it was started later, because the fact that it was a tick-borne infection was not immediately recognized. But obviously the patient wanted to know, well, if I'm on this medicine, why am I not feeling better? Which is a very fair question. So we repeated some labs, including the antibody testing, to make sure that we couldn't find another diagnosis that explained the symptoms. This patient's basic labs, when we checked, were okay. There was nothing else that really jumped out as far as liver inflammation or thrombocytopenia or anything else funky. I don't remember if we checked inflammatory markers. I'm going to assume that the SED rate for sure would have been high. So we extended the course of doxycycline. I think it was a week-long course, so we did another week. Or maybe it was a 10-day course and we did another 10 days. I can't remember. I just doubled the course, not the dose, but how long they were going to be on it. And then saw him again, still feeling bad. So we added a steroid. And last we heard, that made the patient feel a lot better. So I suspect, really even by the time we saw them, the inflammatory process was causing more of the symptoms than the infection itself. The only recognized alternative treatment is chloramphenicol. that is reserved for rare cases of life-threatening doxycycline allergy or sometimes pregnancy. It comes with higher mortality rates, limited availability of the oral formulation, and also a risk of aplastic anemia. So we really want to stick with the doxycycline if we can. Apparently, there were some reports of rickettsia organisms that were resistant to doxycycline, but that has now been disproven somehow. So as far as we know, there's no issue with resistance to the doxycycline. We know that macrolides, quinolones, and sulfonamides are not good in this situation. So it's pretty much doxycycline or bust. Obviously, if they present super sick, they need to go to the hospital since there is a chance that they could die from this. It can be that bad. You can get cutaneous necrosis and gangrene from this, which apparently is sometimes confused with purpura fulminans that you get from meningococcal infections. And along with some of the other symptoms, this can be mistaken for TTP, thrombotic thrombocytopenic purpura. Apparently, this vasculitis has also been misdiagnosed as Kawasaki's disease in kids. You can certainly understand why. Similar presentation, similar lab values. As far as prevention, there's no vaccine for this, and generally antibiotic prophylaxis after tick exposure is not recommended. As I said earlier, that's kind of what we end up doing if a patient comes in concerned after a tick bite. Really, we just throw them on doxycycline and send them on their way. But in general, you should not do that just because someone got bit by a tick. Obviously, you can do things to not be bitten by ticks, wearing long pants and shirts when you're out in the bush, closed-toed shoes, insect repellent on your skin, using permethrin treatments for clothing and other equipment, gear, and then, of course, checking yourself for ticks after you've been outdoors and pulling them off promptly if you do find them. Also important to keep your dogs or your pets tick-free, as those can be vectors for bringing ticks into your house. It's helpful to keep vegetation down, short, so keeping your grass cut, clearing leaves, that sort of thing, taking care of weeds. If there's going to be any long-term complications from this, it's usually in people who had very severe fulminant disease and survived, and that is just a result of the vascular injury and tissue ischemia, as you would expect. So just depending on which systems were affected. As far as predicting long-term morbidity, how soon the doxycycline gets initiated is the biggest predictor of that. So if you go more than 5 days with symptoms before you start doxycycline, you're more likely to have some long-term morbidity from this. We have not seen any evidence of long-term rickettsia infection, so there's no chronic or relapsing disease associated with Rocky Mountain. And I think that's about all there is to say. If anything else changes with my patient that I'm taking care of, I will let you know. It's always an interesting learning experience to see these things in person instead of just reading about them. Of course, I will post the article I used as a reference for you in the show notes. Thanks for hanging in there with me through my little sabbatical. The plan is to get back to doing episodes every 2 weeks or maybe every week. I kind of like every 2 weeks, just so it doesn't feel like such a job. And stay tuned for the formal book announcement. If you'd like to check out the novel I wrote, it's called Crooked Creek Serenade, written under my own name, Jody Marks. It's available now at a whole lot of different places and coming soon in audiobook form to several other places. Thanks for listening. I hope you have a great week, and I will talk to you later. All right, that does it for this episode of Knowledgeable Provider. If you're looking for more content, check out our YouTube channel and our Facebook page. Remember, all of those ratings, reviews, likes, follows, and subscriptions really do help the show, so please take a second and do those things to help me out. If you have a request for an episode topic, or if you'd like to be a guest on the show, I'd love to hear from you. Email me anytime at thekppod@gmail.com. That's thekppod@gmail.com. Thanks so much for listening, and as always, stay safe, take care of yourself, and take care of your patients in that order.